Hi, I'm Dr. Joanne Smith.
And I'm Dr. Corinda Hankins.
And this is A Pod Full of Pediatrics. Subscribe here for more content.
Or go to onecommunityhealth.org.
Or follow us on One Community Gorge. And this is the one where we talk about rashes and eczema. So this is one of our favorite topics because rashes often need a little detective work to figure out what they are based on like kids' age, location, and the timing of the rash and how they feel.
And how the rash feels. Like it's always like a cool thing. And we both really like mystery and detective things. Mm-hmm. And I personally think it's why we like pediatrics.
Absolutely.
Like because a lot of times, you know, your kids don't talk to you. So like you gotta like
whether they can't talk or they just won't talk.
They won't talk. And like you have to like talk to parents and then kind of figure out things that people might not be saying or are saying, but in a different way. Mm-hmm. And then you got to examine. You have to actually examine a child.
Which is why we cannot be replaced.
That's right. AI will never replace us.
No.
We might get ourselves out of business, hopefully,
because we're so good at prevention.
Keep kids healthy. Like I would love to be out of business in that way, but I don't think we'll be replaced by AI.
No. So along that line, we're going to talk about rashes. We can't actually show you the rashes here. Maybe Whitney can put some pictures in. But there's a really good website, dermnetnz.org, which is dermnetnewzealand.org. And I really like that one because it's like you look up a specific thing either based on the name or just what the rash is described as, and you find a great picture.
Yeah, and so we'll try to put those in after we kind of as we talk about each one. Maybe Whitney can put one of those pictures in. But we're going to start rashes with newborns because that's how we've started most of our things.
And that's where it all begins.
It all begins.
Yeah.
But also because newborns have so many rashes.
They do. Because they have really sensitive skin. Like they were living in this bag, this sterile bag of water. Right, and they come out and suddenly everything is touching them.
That's right, and it irritates the skin. But also, they have to shed the whole first layer. So one of the first questions we get is, "Why is my baby peeling?"
Because like a snake, they have to lose that first layer of skin to grow.
And it does not mean that they have really dry skin. It doesn't mean they will have really dry skin. They just have to get rid of that first layer. And pretty much no matter what you do, it doesn't help it along. It just has to run its course for it.
So we're going to talk about some common rashes in babies, but not infectious causes rashes in babies because it's just such a different conversation at this age.
And we're not going to talk a ton about infectious cause throughout these. We'll kind of mention a couple of them, like the ones to really be worried about, but we're not going to talk about any of the others.
So one of the first rashes, other than the peeling, that you see in babies is something called erythema toxicum, which sounds terrifying, but absolutely isn't.
That's right. It is a pustular disorder that occurs in approximately 20%. I think it's way more than that.
Yeah, I think it's more like 50%.
Yeah, I see it in almost every other baby. And it usually starts within the first 72 hours of life, and it looks like little white dots with red around them. It also, it can look a lot like hives.
Right, the tiny little baby hives. And parents say worry about an allergic reaction or infection, but these are just totally welcome to the world, baby.
Yes, they are harmless. They are not anything to worry about. The key to this rash, and one of the ways you can tell what it is that it moves. So it'll at night be on their face, and in the morning be on their chest, and it just moves kind of all over the body, and it always goes away, typically by a month of age.
And you don't need to do anything.
Nothing at all.
The other one that's super common at the beginning is malaria, and this is not like the disease malaria. This is M-I-L-I, malaria. And it's a little white dots. I mean, usually it's where the sweat glands are, so it'll be kind of forehead around the nose. I know my daughter had one straight in the middle of her forehead when she was born, and my husband really wanted to pick it off, and I was like, don't pick it off, because it will go away by itself.
And it does. They have been more common in warm climates, but it can be anywhere where you kind of get the sweat collecting. Because babies actually can't sweat, so they don't sweat normally yet. They have other ways to measure their temperature. It's one of the or to get rid of temperature if it gets too elevated. And so it is a problem for that sense, but because they can't sweat, sometimes that fluid does accumulate in little tiny sweat ducts.
But they'll just leave. Another thing that's really common from the start are nevus simplex, which has all kinds of fun names.
I really like the names. I always call them by their names because my favorite one is angel kisses. So it's the little on their eyelids, they have these little red patches, and the one behind the neck is always the stork bite, as if a stork brought your baby. Obviously, that's not
obviously.
true.
And then the salmon patch is kind of the one in the middle, which is not as cute a name.
That isn't, but they are cute, and they are also very normal. 40 to 60% of infants, and I would say that is really pretty.
Yeah, and they're pretty much
common.
midline, and they will just fade with with time. In adults, you typically don't see them unless the adult's really mad or hot. And then you'll be like, oh, I see the faintness of the little
right.
nevus simplex
It
there.
is still there, but it is really light. And most fade by the time they're like 1 or 2. Like, you just don't see them more after that.
Hemangiomas are birthmarks, but they are not actually born with them. They show up kind of in the first 3 weeks of life.
And hemangiomas are really made up of blood vessels that form incorrectly, multiply a lot, and these blood vessels receive signals to kind of grow rapidly in the first weeks after birth. So what you'll see is they'll kind of start, and then they actually get to their biggest phase by the time they're 4 months, and they're done growing by 4 to 5 months. So it is really impressive in the sense of they can grow pretty fast, and it is why you have to watch some of them.
And they kind of start as a little red dot or a little blue dot, depending on what kind of blood vessels are involved. And then they grow, based on where they are to stretch the skin out in that area.
Yeah. So most of them, like if it's on other parts of the body and you don't have to worry about it, they'll just kind of grow until that 4 to 5 months. And then slowly what we call involute, meaning the vessels shrink and then you'll have like normal skin. If it was a really big hemangioma, like say on your thigh or something like that, it actually can leave a little leftover skin as if the skin was stretched.
Kind of like, baggy and left over there. The ones you worry about are the ones that are going to be on cartilage, so like ears and nose, because they can permanently change that lip. Or if there's somewhere where it's going to affect function. So we really worry about the ones around eyes because they could obscure your vision.
Fingers and toes, so appendages, fingers, toes, penis, labia.
I like how you put
anus.
penis as appendage. That was really good. Maybe around the buttocks. I've seen some really bad ones, like in the buttocks area, because they'll like start bleeding sometimes and kind of ulcerate. So
in the diaper area, it's not a great place for hemangioma. And the reason that we want to catch those is again, most of these will go away. Again, they'll still go away by 3.5, 4 years of age. However, on those areas, they tend to either compromise function, bleed, have other issues, and we can treat these now.
Yes. So if your baby has a little red dot, seems to be growing, make sure you go as quick as you can to see your doctor, because we want to do the treatment sooner rather than later.
Yeah, and if we have more than 5 of them, we also tend to worry
about other things.
Other things, yeah.
Port wine stain is a birthmark, unlike the other two, that does not go away over time.
Yeah, it's a permanent
will come
one.
And stay where it is. It tends not to be midline, tends to be more off the side, and the ones we kind of worry about the most are ones that are on the face or scalp.
Yeah, and that's because they can be associated with some syndromes if they're there, and so we worry a little bit more about those. But they're also darker.
Yes.
It's kind of a darker red. Your hemangiomas are often like this, really bright red, whereas your port wine stains are kind of this darker, almost a maroon color.
Maroon, and they sometimes even a little more purplish in there if they've got some capillaries in there.
And they can be pretty big.
Yes, and they're mostly cosmetic, and sometimes we'll do treatment later if the child is bothered by them, but they're harmless otherwise.
And then neonatal acne, and there is a new name for that, but I don't like it. I'm going to call it neonatal acne.
Neonatal cephalic pustulosis. Come on, we're going to call it that.
Okay.
And it says 20%, but we both think it's way more than 20%.
Yeah. And it's basically an inflammatory reaction to skin colonization with yeast species, which is why they don't want to call it acne, because that's usually kind of other things like bacteria and other
hormones,
stuff. But the yeast species is Malaysia. I don't think I said that right, but interestingly,
so you say it like that. It shows up about 3 to 4 weeks. And then typically it's gone by 2 to 3 months.
Yeah. They do resolve spontaneously. They do not need to be popped. Please don't pop your kids' acne. And you can put a little soap and other stuff on them, but truthfully, they'll just go away on their own. You don't have to do anything at all.
Another super common birthmark in darkly pigmented skin is congenital dermal melanocytosis. And these are the kind of the big marks that looks like bruises at the beginning, especially lower back and buttocks, and they will fade with time.
And they're all those ones that we're really told we need to document these. And then I always forget to document them because I just consider them normal.
Because they are normal, right?
So I'm like, oh, darn it, I forgot to document that.
And they fade away. I always want to notice when they fade away, but I just never notice. No. It's definitely by school age, but I don't know when.
Yeah. And then the ones you do maybe have to worry a little bit more about are, if they're really big, are the congenital melanocytic nevi or moles. So some of the small moles that kind of develop through life, you don't really have to worry about. But the moles as we get older are some that are really large. And really large means, greater than 20
20
centimeters.
meters. Yeah. So, in a baby's body, that's
not
a
20
large.
meters.
20 centimeters, right? I said that. These are ones that take up a large percentage of the baby's body from the start, and you're like, okay, let's kind of evaluate those. But most of the little tiny moles, even if they're not there at birth, they're going to show at the beginning in the first few weeks to months. We don't really worry about.
And they'll grow with you a little bit, but they're never these really big ones that we worry more about. And those just have a greater risk of becoming malignant, which is why we worry about them.
So seborrhoeic dermatitis of the scalp, known as cradle cap or cradle crap, as some people call it, right, is really common.
Allowed to say that?
Yeah, we're allowed to say that. 70% of babies have it, and it shows up about like a month, 3 weeks to 4 weeks of age.
And it is... it's like this yucky kind of flaky, yellow flaky stuff. It bothered the heck out of me. It does not bother babies at all.
No.
So it doesn't itch. It's not uncomfortable. They don't know it's there, and you do not have to do anything about it. I personally was annoyed with it, and because I like to pick at things, I would pick at it, which is not that great. Like it can pick off, and you'll actually pick off the little hairs. Hairs will come with it.
Yeah, and it looks more red and inflamed. And kind of the more the mess with it, the worse it gets. So you really just try to ignore it, put some Aquaphor and Vaseline on it to cover it up. If the scale is in the hair, you can kind of pick it off, but if it's attached to the scalp still, you pick it off, it's going to come back bigger.
Yeah, and the other thing that, I kind of used to do that I thought helped some was the Aquaphor and Vaseline, and then I'd do the little plastic brush where I just very gently brush, and often that put it enough on the hair that I could just kind of get it out of the hair.
But I usually just leave it alone.
But most of the time we do recommend just leaving it alone. If it gets really bad, or if there's some other issue with it, there are some over-the-counter creams that we can use that your doctor can give you. But even those are only mildly effective.
Yeah. Just be patient. It will go away.
It'll go away. And if it doesn't go away by after 2 years, there actually is some things that we'll recommend, because sometimes there is another yeast component or to it at that time. There. So.
Café au lait, which is French for coffee with milk, or café au lait macules are these areas on your skin.
We took French in high school.
They're sharply demarcated, hyperpigmented, which means darker than your usual skin by 2 to 3 shades compared to the skin around it.
Yeah, and they vary in size by very tiny to about 10 centimeters. They can occur anywhere on the body. Again, we don't worry about them unless there's a lot of them. So if there are more, if there's a bunch of cafe au lait spots, then your doctor might recommend kind of following it or kind of talking to another specialist.
And we consider them a birthmark, though usually they're not there right there on day one.
Yeah.
But they're pre-programmed in your chromosomes to show up. So they kind of show up usually in the first, 3 months of life.
And I should say this because the ones that tend to kind of be a lot of them actually will come not just in those first ages of life. They kind of keep coming as you age. So, and then we're going to talk about actual common rashes now. Those are the rashes of babies. These are the rashes in toddlers to school-age children.
Yes, and skin findings can look really different in different people just on the way their skin is, right? So we talk about rashes just like real estate. Location, 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 because that's totally what matters.
And they're also, Joanne really likes this word. I don't know that I've ever used it.
It's such a useful word. Fomites. The word is fomites.
Yes.
The vocabulary word for today.
And that is, and I never use it, but I maybe will start. I don't know. Frequently, it's just a fancy word for any surface that can collect bacteria or material that can cause an infection and spread to others. So that means tables, bathrooms, counters.
People's hands. Clothing. Helmets.
Nails. Yeah.
Yes. It's a fomite. It's a word to use all that together. See, it's saving so much time. Yeah. You can just be like all of them are fomites.
Except then you have to explain it every time.
Not anymore on this podcast. Now we know.
So the acute rashes are tinea is one of them. So tinea, this is one of the ones that gets talked about a lot. Mm-hmm. It's like your tinea corporis, which is the ringworm, another name for ringworm. Dermatophyte infections are prevailing causes of fungal infection of the skin, hair, and nails.
Right. So these are just fungus that kind of live within a surface of your skin, basically.
And they can lead to several different presentations depending on where they are in the body. And the ones on the body itself, tend to not be dangerous, but often if you want to make them go away, we'll need an antifungal cream. That takes a long time to treat.
Yes. And they're acquired through direct skin contact with infected individual or animal, because we see those all the time. The little kittens have them, and then the kids are holding the kittens against their face, and next thing you know, you have ringworm on your face.
And I will say, kids get these a lot more, I think, just because of how they hold the cat, and like, I don't know if they
or how they touch everything.
They touch everything,
They touch
and they
all the
like
fomites.
snuggle it up, and then they're like all of a sudden all over their body. So,
Yes.
Ringworm is a really common one that spreads from animals to people.
And, you know, and again, it's relatively easy to treat on the body, but in the scalp, it's just really,
can be
and it
really
gets really
difficult.
gross on the scalp, like just a boggy, gross
Mess.
infection. So if you
Yeah.
see crusties on the scalp, please let your doctor know.
Yeah. And then impetigo is a superficial staph infection or strep infection of the skin that most occurs often in children, and that I guess is really
It is. I
common
was saying
here.
I've seen more in the past year since I've been here, because I've been here a year, than I have in the whole 20 plus years of my career in Indiana.
It's funny.
just
I've never
super
I just always
common
see it, but yes,
in southwestern Washington
and Oregon.
Northwestern Oregon.
Yes. But basically, it's like these crusts. So it's basically like and it's honey colored. Like there's really nothing else that looks like it, to be honest.
Yeah, and not like in a positive way, honey colored. It's not attractive.
It's not. It'll be almost looking like little scabs or that type of thing with this honey-colored crust over it. And it often happens mid-face, so you'll see it underneath the nose and around the mouth of kids. And it really just comes from, it is very highly contagious, and it comes from direct contact, skin-to-skin contact from individuals.
Or fomites.
Or themselves.
Or fomas. Yeah, and that's the individuals will kind of spread it within themselves. And one of the worst ones I saw recently was someone with acrylic nails, teenager with acrylic nails with lots of piercings. And so they kept touching their piercings, and then they were just spreading it all over themselves.
And it can be really hard to treat then, because if you don't actually treat where it's coming from, it'll just come back. So
yeah, so we usually do topical antibiotics for the most part, unless it's just too far spread. Then you have to do oral antibiotics.
yeah, and topical works really well. Like if you catch it early, it's really easily treated. So, and then you have other strep rashes. So that's typically a staph or strep rash, and that's really common, like around the face, like we said. But there's other staph and strep rashes that we kind of worry a little bit more about, or that can be fairly common. And one is called scarlet fever. So it's the one that you always read about in the books, like Velveteen Rabbit. Velveteen Rabbit had scarlet fever.
It would sound so terrible, but it really is.
It was terrible at the time.
It was, because they didn't have good antibiotics.
They didn't have amoxicillin.
No, they didn't have amoxicillin.
Yeah.
It's a sandpaper rash, and it tends to be just on the trunk, very symmetric, and it really does feel like you're touching sandpaper.
Yeah, it is, and again, classic. Like this is where I like talk about rashes so much, in that, like parents will often send me rashes, and I can sometimes send me pictures, and then sometimes I can figure them out. Like again, just based on location and what they sort of look like. But there are some where you really have to touch them, and this is one of those that it has this sandpapery feel that again just really doesn't come with other infections. Like it is classic for scarlet fever.
And so you treat it with antibiotics, and then it'll kind of peel off and go away and no longer be contagious. Another scary strep one is staph scalded skin syndrome, which is 4 S's, and that is a quick onset, really peely, really sick kids, peeling red rash, blisters, and you will know your kid is sick, and you'll want them to see the doctor right away.
Yeah, and that one does need to be treated very quickly. And so again, while they can look like the same in the sense of like this overwhelming kind of redness to their skin, it's like that sandpapery rash, very different from a staph scalded skin.
Hives. So the most common cause of hives for a kid is a virus.
It's a virus.
It's a virus.
It's not an allergy.
No. It can happen with allergies, but not by itself. With allergies, you're going to have vomiting, diarrhea, something swelling. If it's hives alone, it's a virus until proven otherwise in a kid.
Yeah. So, and that actually is really important, because we get a lot of parents who come in and are like, we're trying to change everything. We've stopped detergents. We've stopped this food. We've stopped that food. And often their allergy was not the cause of the rash in the first place, and you will have a virus. So interestingly, it can be at the beginning of a virus.
Right. It can be the first signs of the virus, so you don't even know what virus it is.
Or it can be like a week after the virus.
Yes.
But you will get a history of virus somewhere around these hives, and they can be quite a long time. So that's my other thing. You know, we have hives, are another name for hives are called urticaria, and it's basically those splotchy red, like,
that move by
like bumps.
definition. They're not fixed lesions. So
Yeah.
you're like, okay,
They
now
move
they're in different
around.
places. And they can come together and become a really big hive. Doesn't mean they're worse. It's just that's the histamine in their skin.
But they can have like this acute urticaria reaction, which you think like acute, right? Like that's going to be like a few days. No, 6 weeks.
Right. It's not considered chronic till it's 6 weeks or more. So once they come, they can keep coming. And they're worse when the kid's hot, which they'll like after they wake up in the morning or take a bath, or they just run around and play.
Yeah, and all of a sudden you'll see ones that you like thought were gone, and then they'll just pop right back up again. The other thing about hives that I think is really interesting and important to know is that they are itchy. So whether they are from allergy or whatever else or virus or whatever, they're all itchy. So these really do bother children, and you do need to use antihistamines. Otherwise, you are going to have a miserable child, and therefore you will be miserable.
Yes.
So,
and I tend
so
we tend to
treat.
recommend the long-acting antihistamines like Zyrtec or Claritin because Benadryl will work, but then you'll have some rebound afterwards. So it's better just to be given something that will just stay in their system all the time.
Yeah. And you don't have to worry about it. Like you might use that every day for, again, up to 6 weeks. Totally okay to do that with like a Zyrtec or a Claritin.
Yeah, and hives in general are never worrisome to me unless something else is happening at the same time.
Yeah, if they do have hand or face swelling, if they're vomiting, if they have a lot of diarrhea, then I'm way more worried about other reasons why these hives are happening, and then we need to again be detectives, figure out what's happening.
Petechiae and purpura, though. So these are petechiae, the little tiny red dots. They're usually smaller than 2 millimeters, and you can't feel them at all. They look like little bright red dots.
And purpura are like basically, if you can think about like all of those together and like this big bruise looking thing that is a darker kind of color, but it has like, you can feel it. It actually is raised above the skin a little bit.
Palpable purpura, that's what we say.
Yeah.
And the petechiae, both of these are concerning. When you see these, we're like, we have to be on the lookout. But again, these are detective skills. Sometimes if it's just petechiae, we have a reason for it. They were throwing up a lot.
Right. And you'll see, like, if they're throwing up a lot, occasionally they'll have petechiae just from kind of that excessive force, because petechiae and purpura are just broken blood vessels. So those are vessels that have come to the skin and broken for some reason.
Capillaries are leaking.
What we're worried about is that if they're breaking from trauma, like vomiting or bad coughing, or even like passage through the birth canal.
Yes, you see them in little newborns.
Yeah, like
or
those are all petechiae.
The classic one we see with slide injuries, right? Either a slip and slide or going down the slide and then you just
have
go
these
down,
little
strip
like
down your back.
Petechiae.
Yes.
That goes with an abrasion, right? And so those we don't worry about so much. It's the ones that are kind of spreading and we don't have, like, they're all over and maybe associated with other things like bleeding more, or kids are really sick with them. Fever. All of my fever with petechiae or purpura, I really, like, that's scary.
Yes,
like, that
they need to go to the
needs be
emergency
worked
room and get evaluation right away.
Yeah.
All right, so that's kind of the overview of the most common acute ones. We're going to talk about chronic ones. Like the most common chronic one is eczema, but we're going to save that till last.
That's the last one. You have to wait.
So keratosis pilaris is another one that's super common. It's the thing that's like the little goose bumpy on your arms, your legs, and your cheeks, right? And it feels really dry and bumpy. It's about 12% of populations in all throughout the global population.
And it is really common in families. So this is one of the things that we always see. Like, parents will come in and they're really worried about this really dry skin on their kids' arms. They're like, I think it's eczema, but nothing I've tried works, all of that. And then we'll like, hey, do you have this? And almost always one of the parents will have it.
Yes.
Yeah. Oh, yeah, their dad has that. Or, yes, I have it. Because it is really, there's a really big genetic component to it. It is not itchy. It is not dangerous. And it really, you don't need to do anything about keratosis pilaris.
Yes, it's not bothersome. It's really cosmetic. So sometimes in the teenage years, it bothers kids, or it sometimes could contribute to acne because it blocks up the pores, right? And so we can recommend doing a keratolytic, which is a salicylic acid kind of lotion, or I just recommend like a sugar scrub and thick lotion.
The hard part about that is to really get rid of it, you have to irritate the
You have to
skin.
make it look worse before it gets better.
And it will be irritating, and maybe even like have a tiny bit of pain with it. There's no reason to do that to a baby or a child.
No.
But for adolescents, if they really want to have it, like because it bothers them, absolutely let them make that decision. But wait until they can make it, because truthfully, it doesn't bother kids otherwise.
Molluscum contagiosum sounds so scary, but it's actually just super annoying.
Yeah, it is really just annoying. It is a virus. It is kind of on the wart virus family and can look a lot like
little
a wart.
tiny warts, little pearly papules.
And sometimes they even have an involution in the middle, like a little kind of hole in the middle of it, and that's how we absolutely know it's molluscum. Again, very characteristic.
Yeah.
But they can come in groups, and that's a little bit different than warts typically. Yeah. Typically warts will be kind of one or two
until they start spreading.
Yeah, but these will often be like a whole conglomeration of like 4 or 5 or even more than that.
And they love warm areas, so like armpits, like back of the knees, groin area. They just kind of show up there.
Yeah, and they are contagious, so you'll get them from other like fomite areas.
You used it, and you wanted to.
Or people. I classically see this from in the summertime a lot. And I swear I think it's those big lily pads in the swimming pool. Like one kid will like pull himself up and it'll scrape, and they'll have a little eczema and molluscum, and then the next kid does it and they'll get it right after them, right? So they can spread in that manner. Again, they're not dangerous, they're not harmful, they don't tend to be itchy, and so you don't have to do anything with them.
No, and they're so weird because it really is immune system related. Like my son had it pretty bad. My daughter didn't have it at all. It's like the allergic people, and especially if they have some eczema and their skin barrier is broken down, they're the ones that tend to get it.
And they tend to spread it. So, like, for example, like when I see the worst molluscum tends to be with children who have eczema, who already have a barrier of their skin that's kind of compromised in some way, and that's itchy. And so while molluscum doesn't tend to be itchy, man, if you have a child and it's in an area of eczema, they will scratch that and then spread the molluscum everywhere. So it can be really hard for those children.
And like we said, they can be treated like warts with some freezing or chemical agents. There's a medicine called cantharidin that I used to treat molluscum pretty often with, but then I started seeing the scars that were there because I treated them. And if you let them go away by themselves, they tend not to scar.
Well, and just like warts for me, like, warts are not harmful. These are not harmful. They are not going to like hurt your child. And if I'm using a medicine that actually will cause more pain and difficulty than the wart itself or than the molluscum itself, I tend not to do it.
Yeah.
Like, we can treat warts really effectively by freezing the heck out of them and causing a lot of blistering. I don't love that. Like, no. I'm now causing more pain and difficulty than the actual thing itself. And so, yes, I will freeze, but I don't freeze to where I'm causing a significant amount of pain or blistering. Because to me, it's going to go away by itself if I do nothing.
And molluscum can take up to 2 years to go away. It's not a quick one. That's why it's in the chronic category, right? Yeah. Often when they start to go away, they'll get like a big patch of eczema there, like dry, red, itchy skin. And you put steroid cream on there, and that means good. This is almost burned out right here.
I love what this is called because it's called an id reaction.
That's our psych background, right? We're both psych majors,
so
right?
The id is like the self, right? If you're thinking about it, it's like the self, like your self is taking care of it. So all of a sudden you're having an immune response to that thing, and then it goes away afterwards. But it can look pretty gnarly as that's happening, and so you can put some antibiotic ointment or some steroid ointment on it, and that'll help it a little bit at that time. And then there are some other creams and ointments that if it's really like I have a really bad eczema kids, I will try to treat molluscum sometimes with some of those that are not, but I treat it just very carefully to not cause worsening issues.
There. Psoriasis is another chronic inherited condition that is not very common in kids, but occasionally we'll see it. And it's very different than adult psoriasis for the most part because it looks really more like eczema, a red, a dry patch as opposed to anything with a silver scale.
And you can do some things for it, like phototherapy and ointments and that type of thing. We don't have to do the biologics. It's just not common in kids, and you don't need those, especially in this early stage of psoriasis.
So next we're going to talk about 3 rashes that all have the same first name, but are all completely different.
Yeah.
And, I don't know why they have the same first name. But pityriasis rosea is a kind of random rash that usually occurs like in older kids and teenagers, and it's starts mostly with this herald or mother patch. So it's like a single round, oval, really defined lesion on the chest, neck, or back that's like 2 to 5 centimeters in diameter.
And then 1 to 2 weeks later, they get a lot of oval lesions. Again, typically hyperpigmented, so it means like more pigment to the skin. And they come in this cool shape of a Christmas tree on the back.
Or as my arborist son would say, it's a fir tree.
A fir tree.
He likes to differentiate that. They're not all Christmas
trees.
Yeah,
and they just kind of have like these branching out of it in these patches. So it's really, again, very characteristic. And so most of the time you're like, oh, that's what that is.
It is pityriasis rosea, and it lasts 4 to 6 weeks. So this is why it's under our chronic category.
Yeah.
And it can last for several months sometimes. And it doesn't mean it's the worst case. It's just your skin. What is it doing with it?
Most of the time, it doesn't bother kids very much. Occasionally, a little bit of itching, but not much. Initially, as it starts, it can be associated with like headache, malaise, that type of thing, but it doesn't last.
Right.
And then otherwise, it's pretty asymptomatic, and you don't have to do anything to treat it.
Yeah, and if it's itchy, you can do oral histamines, antihistamines like we talked about, and then there's some anti-itch creams like Itch-X or Sarna, which are kind of nice just to take away the itch at that moment.
And then there's pityriasis versicolor or tinea versicolor. I've never called this pityriasis versicolor. I've always called it tinea.
But it's not even a tinea.
I know it's not a tinea. I know. I just like what. Like,
I don't know. Neither name's weird. So it's a superficial fungal infection that's not a dermatophyte like tinea. It's malassezia, which is the thing that causes cradle cap. What? And it's either can be lighter lesions or darker lesions, and it's in the sweaty areas. So classically, it's like across the chest, the front of the chest.
And they'll get these little just like light, like kind of white spots, like kind of all over in the summer, or on the cheeks sometimes. Like
yes,
they'll
definitely,
get them on the cheeks, and then you'll just get it. But it can look really hypopigmented, and a lot of times they actually mistake these for like a tinea. Like a ringworm type thing where they're worried about it. And I think maybe that's from the name, I don't know. But treatment is typically similar in the sense that you just do a topical antifungal
shampoo. And it's one of those rashes that kind of shows up every summer because you're like, oh, I'm not getting tan in those areas. Now I can see it. And then later on, you're like, oh, it just faded away again. It's not contagious.
And it can take months or years to fade.
And it's not related to poor hygiene because I have sometimes parents accuse their adolescents of that.
Oh, that's good.
I know.
Yeah.
They might have poor hygiene, but this rash is not because of that.
As an adolescent, they might have that.
Exactly.
That's not the reason. Maybe they're just really accusing it because they actually want them to shower.
Maybe it's just like a good excuse. I don't know. And the third pityriasis is pityriasis alba, which again is a misnomer because this is really just a form of eczema.
Yeah.
That's just kind of lighter patches with a little scale that is on the skin.
And then finally, we talk a little bit about moles or benign nevi. And most moles are benign, especially in kids. They kind of grow as kids grow, but we're looking for those same things with them as an adults, like if we're worried about them. And very rarely are moles ever a problem for a child.
Yeah, and moles begin to appear usually about, first 6 months of life, and they increase in number until reaching a peak in your 20s. And the cool thing is they can come and go.
Which I actually didn't know.
I know. It's a big turnover of moles till about age 20. For like 3 to 4 years in early adolescence, the number of moles can increase by 40 to 60%, but 15% of them can disappear.
Which is kind of cool.
It's really cool.
And then when you're worried about it, the red flags for a mole in kids are family history of melanoma, so especially in people less than 60. Larger size, greater than 10 millimeters, irregular borders, so all of a sudden they look weirdly shaped and they were circular.
You're like, where's
before.
the edge? I can't tell what the edge is.
Ulceration or just really, really fast growth.
And the moles are going to grow in kids as kids grow, but they should always take up the same percentage of their body that they did before. So if you notice anything that's kind of looking weird or bigger to you, just have your doctor check it out.
Yeah. And then we're getting to eczema.
Woohoo! Yes. And
we say this because literally a lot of our practice is eczema.
Yes. Again, the stats say 10 to 20% of Americans will have it. I think it's more than that.
Yeah, I think so too.
Yeah.
And part of it is that eczema is a type of dermatitis, and there's lots of different types of dermatitises. So again, some things get like kind of combined with eczema that probably aren't. But eczema is really common. It affects 31 million Americans. And the cool thing about eczema in babies and little kids is that often they do outgrow it.
Right. The skin is just more sensitive when they're little, and everything keeps touching it.
Yeah.
So eczema, as you know, is dry, itchy skin. I'm sure you know someone who has that dry, itchy patches.
But this is one of those where I really like to touch the child because it is really important to feel it. Eczema feels different than other rashes. So sometimes they can look very similar. And in fact, there's like this nummular type of eczema that can look very much like ringworm.
Absolutely,
right?
yeah.
And so like I see a picture of it and I'm like, which one is it? But then I touch it and I'm like, oh, it's eczema, right? Like this is nummular
That's why
eczema.
you can't be replaced by AI.
I can't.
Until maybe they can have sensors on the AI, though, that can like differentiate.
Nope. We're never going to get replaced.
There are several kinds of eczema. You talked about, say, atopic dermatitis is the classic one. That's like atopic means allergic. Contact dermatitis, which is like stuff touching your skin, freaks it out. Dyshydrotic eczema, which you mostly see in sweaty little hands and sweaty little feet. Mm-hmm. Neurodermatitis, which we don't really see in kids that much. So we talked about nummular eczema. And seborrheic dermatitis is kind of cradle cap in more than babies.
Yes.
So it's when you get the crusty yellow
Older
stuff
kids.
in older kids.
So eczema can affect anyone at any age, but it usually does appear during childhood and lasts into adulthood. If it appears in childhood. If it appears in infancy, a lot of that will go away. And you might be more at risk at eczema if you have a family history of eczema.
Yeah, exactly. Or just an allergic family history, right?
Yeah.
Just kind of asthma and seasonal allergies and stuff like that.
Yeah, and that will make you much more likely to get eczema and kind of keep it. Several factors cause eczema, including...
And also, not only cause it, but like affect it in how bad it is. Right?
Absolutely. Your immune system, if you have eczema, your immune system basically overreacts to small irritants or allergens in your environment. And if you get triggered, and that can be just like a virus.
Just a cold, right? A cold is going to make your eczema freak out.
Yeah. All of a sudden it creates inflammation, and that inflammation decreases the barrier of your skin. Like it inflames it, and it ends up like basically making the barrier to your skin not as good as it was.
And then we talked about genes, right? This really runs in families. Like especially if you have like pollen allergy, well, during your spring, your eczema is going to be worse.
Yeah, asthma, it often associated with eczema as well. And then you have basically the reason for that is that the same things that causes that ATP are genetic mutations that cause that skin barrier function to be abnormal or not work as well as it should. Barrier is so important.
Yes, that's what your skin's main job.
Yeah, it is the main job of your skin.
And things in your environment can definitely make eczema worse. And, you know, people with eczema can have a reaction even when nothing touches them, but all of us can have contact dermatitis, which is when something touches our skin and freaks it out. It's just that people with eczema can have a way worse reaction with their contact dermatitis.
Way worse.
Yes. And so contact dermatitis can happen at any age. You know, in the infant, it's usually a body fluid. So this is when they can get a rash from saliva on their mouth, or milk on their mouth, or just a really bad diaper rash that just won't go away.
Yeah, and then you have other like big people can get like an irritant dermatitis from their laptop.
Right, and this is why kind of our detective skills kick in. Like that's a classic thing where all of a sudden just the upper thighs have a rash. What is that? The front of the upper thighs, and you're like, what sits on your upper thighs a lot as a teenager? Oh, your laptop. Oh, yeah. There you go.
But it can also be like poison ivy, is a big contact dermatitis. That looks different. It truly does. It does not look like eczema. It typically has more lines. It's in areas where you might get contact from it, except for if it's on the animals and then you hug the animals, because then you're like, wait a second, it's in different places.
Yeah, and that's what every summer we have this detective game where you see the 9-year-old boy with it just on hands and penis, and you're like, what is that? Oh, you peed out in the woods when there's poison oak there.
Yes. It's not so fun.
No.
You can get it on your bottom too if you poop, or don't.
Just bring it all out there. You wouldn't let me say crap, and you just said that.
Poop is better.
It's okay. So, contact dermatitis can be anyone, but you just have to play that game of like, what caused it in you specifically. I've seen it before in kids with school uniforms. Like there are certain people with, sensitive skin that die of the school uniforms, and you can see exactly where their shirt and their pants or skirts was.
You can have emotional triggers too, like stress can sometimes cause and make eczema worse. One of the big ones we get all the time, especially for infant eczema, is this really worry that it's something that moms ate, so that
or something the kid ate,
or like as they get bigger, something the kid ate. So that eczema is really caused by that food allergy. And there's actually some really good studies now between like dermatologists and allergists, who are the ones who treat these the most, right? Eczema is not caused by food allergy.
No.
Food allergy can totally make it worse, though.
Right. If you ate something that you were allergic to and you had eczema, your eczema is going to flare for sure. But if you had isolated eczema alone with no other symptoms, it's not the food.
It's not the food. And so, like, I really I encourage mom not to restrict their diets because you can actually end up, because eczema, like, will just come and go with all of these other things, right? Like, all of a sudden you're, like, restricting everything. And that's not healthy for mom. It's not healthy for baby. Everybody's mad and upset.
Everybody's grumpy, and you're not helping eczema, and they're just itchy and grumpy anyway, right? And now you're taking away the food they like.
So you don't need to do that, and you don't need to worry about it. If it is a food allergy, it's going to have other presentation with it. So you're going to have hives. Absolutely, if they had eczema, the eczema might get worse, but you're also going to have swelling or like
diarrhea or vomiting.
All of those things are kind of more common in your food allergies. And if you don't have those, try not to stress about it, and let's just treat the eczema, because that's the most important thing.
That's the most important thing, is to make your skin barrier good again.
And it is really important because eczema, for kids who have really bad eczema, they are miserable. You look at these infants that have it on their back and on their things,
scalp, and they're just reaching and scratching all the time.
My kid's not sleeping. Well, that's because they lay down and they're rubbing all the time.
And you see them in the high chair like a bear on a tree. They're like going up and down like, oh my God, my back itches so bad.
And so they can't itch it themselves very well, and so often they will just be uncomfortable. And so treating that, helping them reform that barrier, but also treating the inflammation that's causing all the itching is so helpful.
And what's important for treatment is just keep doing it, right? This is like a lot of things we talked about with parenting, is like you just have to do it all the time and make it normal, right? So you want a gentle or sensitive skin moisturizer, like an emollient, and we like the Cetaphil CeraVe kind of brand. But there are definitely people who have a lanolin sensitivity that they need to do something more like Vanicream, and really it's some trial and error. Put lotion on your kid's skin and see what makes their skin feel better and is not annoying them.
And a lot of them, a lot of dermatologists will recommend like Aquaphor, Eucerin, those types of Vaseline even as early ones. And those can be great. Most kids as they get older don't like the greasy feel to the skin, and so they really start rejecting it and not letting you use it anymore. And then they won't let you like put it on, which is problematic because consistency is the most important part of it.
Yes.
So again, that's where you kind of can find the ones that work better for your child. I do like the Cetaphil line, and the Cetaphil ointments that are really thick and cooling are actually, I find, the best for bad eczema. So like your Cetaphil CeraVe often works really well, but something that can pump, you can do it fast.
Yes, that's like with my son, I just need something fast, like just have a pump and put it on really fast before he left, right?
Yeah.
And it's really taking a short bath every day, I feel like works the best, and then putting that lotion on even before they dry off, right?
Yeah.
Just have it right next to the
bathtub.
bathtub.
Pat them and then just like lather them down with it. It is interesting because you will get this argument with different people talking about baths, and some people will say, "Oh, baths were way worse made my kids' eczema worse." Baths are if you stay in the bath for like
don't let the
20
skin
minutes,
get pruny.
30 minutes. If your kid is getting pruny, he's going to come out and have a lot more drying of the skin. So that's really drying out the skin, even though they're in a wet spot, right? So instead, you just do really fast 5-minute baths.
No bubble baths.
And then, nothing that kind of like irritates the skin at all. And then pat them dry and like lather them up. And that helps, like again, really truly helps make sure that barrier stays healthy.
And any areas that are like irritated and red, put steroid cream on there.
Yes.
Right? And
do not be afraid of steroid
cream. Do not. And this is topical steroids. And it's not going to our whole body. It's going to the area that is bothersome. And what they do is decrease the inflammation so the skin barrier can heal. And they also stop the itching, so they'll leave it alone.
Yeah, and that is huge. So for really red areas, you want to use a stronger steroid ointment. And for your pink ones, you can get away with a lighter steroid ointment. But steroids are good for eczema. They really decrease your inflammation. They make your child less miserable. It is so nice.
Right. And and we have eczema action plans, like we have asthma action plans, where we're like, this kind of breakout, use this cream, this kind of breakout, use this cream, because there's been a lot of studies to show that if you're aggressive and you're higher steroids from the beginning, you're using them less time because you're hitting it where it hurts and kind of getting them through it instead of having this chronic inflammation that's going to cause more scarring.
Yeah. And the other thing that we get is they're like, oh, they actually got pale from the steroid. Actually, the paleness to the skin often does not come from the steroid. It comes from bad eczema. So if you have skin that's been inflamed for months, you are actually leaching some of the melanin from the skin. Again, we're injuring that skin. And so when it heals, it actually heals with hypopigmentation. It's usually one of those times where I tell parents, like, this is an area of untreated eczema. That's why they get that kind of color to their skin. So we really want to treat the eczema with emollients, really, really emphasizing emollients 3 times a day even, a lot of emollient usage, and then steroid ointments at least twice a day when it's inflamed.
And then oral antihistamines are fine too. There's a lot of these kids, when they have a flare in the summer, they're hot and sweaty. You got to give them a little Zyrtec before bed because they're just going to be itching in their sleep when they're hot.
And we also kind of said that some of those, not babies will have allergies, but those older kids might also have allergies that make this a little bit worse, like
seasonal
environmental
allergies.
Or seasonal allergies. And then if you really can't regulate with those, they can see dermatology. You might go to immunosuppressant or other light therapies to avoid this, but typically these mechanisms with really good emollient and topical steroids work great.
Yes. So I'm Dr. Joanne Smith.
And I'm Dr. Corinna Hankins. We hope this information helps you to keep your child's skin healthy, happy, and safe.
Thank you for listening.